Rahman Rahim. So today we'll be doing the practical in this session, practical of or the both the pathology lectures which you have been given last week. And is it okay? The sound is okay?
Yes, it's good.
Okay. So yesterday also there was a lecture, and last week Dr. Ahmed took the lecture. So it is in two parts actually. It was last year divided into two, but now I've combined it as one practical. So in this, the first part, we'll do the obstructive lung diseases. I hope you all know what are obstructive lung diseases. It's a kind of mixture. Pneumonia is not an obstructive lung disease. And then we will see the asthma, chronic bronchitis, bronchiectasis, emphysema. And these were added later on. Some of them are the restrictive lung diseases. So you should be knowing the difference between obstructive lung diseases and restrictive lung diseases. So first we go to the most common and most important one is the Lobar pneumonia. You must have that in detail. I'll quickly summarize that there are four common stages. The first one is the congestion, which occurs in the first day. Congestion means the blood vessels get full of RBCs. Vasodilatation, and the blood vessels will be full of RBCs, congestion. The second stage is the red hepatization, and third is gray hepatization. Hepatization means, can anyone tell me what is hepatization? What is hepatization?
Look like liver.
Yes, it feels like liver because normally the lung is spongy, soft, but in this disease, it becomes hard, it's firm and solidifies, it's consolidate just like a liver. So that is why it is hepatization. And in the beginning, it is red because there's more congestion and more RBCs. And later on, it becomes gray in color because of the more neutrophils and macrophages. And finally, the fourth stage is the resolution stage, in which the inflammation finishes and it becomes normal. In most of the cases, it finishes, becomes normal. Resolution is completely normal, but sometimes there are complications. This is another good diagram which was present in this file, which I've inherited for the few years. So for the first stage of congestion, the wall of the alveolus is thick. Normally it is thin, so it is thickened, congested alveolar wall. The cavity is full of serous exudate. Anyone knows what is serous exudate? All right. See, the exudate is the fluid that is obtained in inflammation, exudate. So when it is water-like, we call it serous. Water-like means when you get allergy and viral infection from the nose, we get the water-like secretion from the nose, it is serous. But the pus is usually purulent, and suppurative is pus exudate, then membranous exudate, fibrinous exudate. So in this stage, the fluid is water-like in the beginning. It is serous exudate in the beginning, in the first stage. Then you can also find bacteria, especially the pneumococcus, which is the commonest organism responsible for pneumonia. And then you can see polymorphonuclear leukocytes, which are few in the beginning, but later on in the second stage, you see many polymorphonuclear leukocytes. The wall is still thickened, the exudate increase, and it is more thick. RBCs, they are come. Then the polymorphs are also many, and there is also fibrin. Fibrin fills the space. This thread-like fibrin is present. So now, because of this, it is called red hepatization. It is now solid looking. It is full of fluid, and they're full of RBCs and WBCs and fibrin. So it is red hepatization. In the gray hepatization, now it's becoming normal. Now the wall becomes thin. The congestion of the alveolar wall is becoming thin. There's less exudate. RBCs, they disintegrate and disappear. But you may find some few dead polymorphonuclear leukocytes, the neutrophils. and the fibrin is also decreasing in size. So that is the stage of gray hepatization. Still, it is solid looking. And finally, the resolution stage, the wall is normal, thin wall, and the lumen and the cavity is now empty, and only few debris is left, which is removed by the macrophages. So these are the 4 stages explained by the diagram. And this is the difficult thing. When you see the real thing, it's completely different from the diagram. So this is lobar pneumonia. When the lobar pneumonia means when the full lobe is involved by the condition. So can you tell which one is normal, which one is consolidated? Anyone? Yes, any guess? Good.
The lower one.
Yes, mashallah. So you say the lower one looks like more solid. Of course, you can confirm only when you touch it, but by the diagram, by the books, you see it's more like grayish brown in color because of the exudate. Here it is only congested. It is dark in color because of the increase in the blood supply. So that is the difference. Mashallah, this is the lower lobe is the congested one, and you can see the difference. But within each lobe, the whole lobe is very similar. It's not much different. So within the lobe, there's no difference. That is why it's called lobar pneumonia, when the whole lobe is affected. You'll see the difference when we do the bronchopneumonia. You see the difference in this. So whole lobe is consolidated brownish in color. So these are the gross features. And at this stage, I must tell you, everyone should know this star means this is an important slide. And I have made some question for your quiz or the exam. So be careful about these slides. This is my practice, especially when I teach the dentistry students. And I know what questions I'm going to go in. Here, I'm not sure. I give the question to the department, and then they select from that. So, but I tell you that I've made question from these slides, which have star on it. So the gross features are 3. There's consolidation, grayish brown in color, and dry and firm in appearance. So these can be a question of MEQ. You know the short theory question, or it can be an MCQ also. And I can also write a history on it and then give a question on it. So these are the gross features of lobar pneumonia. Again, this time when I was visiting the preparing for you, these are some of the pictures from your textbook, the Robbins book. So that these are the new edition. You may not find these in the file which I sent to the e-platform. So if you want, I can send this file again back to Muhammad, and then you can share it. You can share with the class. So this is the picture taken from the Robbins. It is slightly different, but it's more clear now. Now you can clearly see that this is firm and solidified looking, and this is the normal lung. So this is the one, the lower lobe is involved by the pneumonia. This is the microscopic feature. If you look, this is the gray hepatization. Again, I must tell you that sometimes there's overlap. You cannot differentiate between red and gray hepatization. But in this, you see the alveolar septa are thickened. They are very thick and they are congested. These are the alveolar septa. And the cavity is full of inflammatory cells, fibrin, RBCs. So these are the cavities which should be filled with air. Normally they should be clear, filled with the air, but they are now filled with inflammatory cells, fibrin, RBCs, etc. So this is the microscopic feature of lobar pneumonia in the 3rd stage or 3rd phase called gray hepatization stage. This is the picture from the Robbins, which may not be present in your file, same picture. But interestingly, I'm telling you that Robbins called this a red hepatization. In the description, it has written red hepatization, but we can see that there are more WBCs than RBCs. So there's always a gray area. So don't worry. These are not the questions you see. You don't see in the clinical practice. This is just for the theory. We have to tell you that in the beginning there's more RBCs. It's red hepatization. Then it becomes gray hepatization. So in this also, you see the wall is thickened and congested with RBCs and congestion, and the lumen is filled with neutrophils, mainly neutrophils, RBCs, and some fibrin. So same features, the microscopic features in the lobar pneumonia. But sometimes it does not resolve. It does not become normal. Sometimes it becomes organized, sometimes become fibrous, depending on the immunity of the person, depending on the virulence of the organism. Some of the viral inflammation, sometimes they get organized, means fibrous. So this is the picture from your book in which they are showing fibrosis. This is all fibrosis with fibroblast and some of the macrophages. On this side, this is normal. You see on the upper right corner, this is the normal area of alveoli filled with air. So some part get fibrous. This happens in very minority of the cases. This is again, one can understand things easily with the diagram. When you see the real picture, it becomes difficult. So this is the diagram of the lobar pneumonia. The whole lobe is affected. And this is the bronchopneumonia, in which there's patchy involvement. This one is normal, but in this you can see the patches. Some are normal areas and the red are the inflamed areas. So this is the difference between bronchopneumonia and lobar pneumonia. Bronchopneumonia is also called lobular pneumonia because it only affects the lobules in the beginning. So this is the gross picture, gross diagram, specimen of bronchopneumonia, also known as lobular pneumonia, in which there's patchy consolidation. The red arrow is showing the normal looking completely, just little bit of congestion in the lung, but these are the consolidated areas. These are the consolidated areas, which are blue arrowed, and then as the inflammation increases, they combine together, they become larger. This is called confluence of these areas, and they become larger and larger. And if depending on the immunity of the person, they can get converted into lobar pneumonia. So these yellow arrows are showing the confluent areas in the lower lobe. And these areas are firmer. They are firm, just like liver. And this is soft. The dark brown areas are the soft, just like the lungs. So this is the same thing, but this is patchy. This is not all the lobe is involved. It is patchy area. So this is lobules are involved. That is why I also called lobular pneumonia. Just to quickly go through the other slide or the disease, we have to quickly go through the normal bronchi, which are rounded tubes, which have cartilage in them. And the lining of the bronchi is smooth and glistening, shining. Microscopy has been asked to revise. This is a small bronchioles without any cartilage. Can anyone tell me is there any cartilage here? These are the cartilage, okay? These are the hyaline cartilage which are present in the wall of the bronchi. But this is the larger lumen lined by pseudostratified ciliated columnar epithelium, little bit of mucus, and occasional inflammatory cells. This is a group of chronic inflammatory cells. Only in the larger bronchi you can see some little bit of chronic inflammation. This is normal because all the time we are getting the bacteria inside. So you may find some inflammatory cells normally. But when we look at chronic bronchitis, can you say, how can I remove this? This is coming over. The chronic bronchitis is written here. The team panel is coming here. So it is chronic bronchitis picture, microscopy. On the left side, you can see there's increased number. That means there is already present some chronic inflammatory cells, but there's increase in the number of the chronic inflammatory cells in the mucosa and the submucosa. This is the mucosa and the glands are in the submucosa. It says similarly, if you look at the right picture, this is the epithelium, pseudostratified ciliated columnar epithelium. And in the mucosa, you see these chronic inflammatory cells. These blood vessels are called congested because it is probably in the stage when this is the beginning. So these are the congested blood vessels. This is an arteriole. We call it arteriole because you can see the muscle also. The muscular wall is also present. So this is an arteriole, and these are all the capillaries and venules, which are full of RBCs, and a lot of chronic inflammatory cells. All these are the lymphocytes and mononuclear cells, chronic inflammatory cells. But there's another feature which was missed in the previous years, but I found it in your textbook. One picture is present. Otherwise, you can see that chronic bronchitis is not a specific histological diagnosis. We call it chronic bronchitis because of the clinical features. You all know, you have done the lecture. It is called chronic bronchitis because there's persistent productive cough for at least 3 consecutive months in at least 2 consecutive years. So this is the definition you must have been told in the lectures. So persistent means it remains, it comes and goes, it remains for a longer time. Productive, what is productive? You know what is productive?
With mucus.
Sorry?
Mucus. Mucus.
Yes, mucus or sputum. The correct word is when you call a cough a productive cough, means it is giving sputum. The person is making it come out of the throat and the mouth. So that is productive cough, mashallah. Sometimes you get dry cough because of just viral infections or any irritation in the throat. We get cough, which is dry cough. There's nothing coming out from the mouth when you cough. So that is dry cough, and this is productive cough, mashallah. So this can happen for 3 months in 2 years. That is the clinical definition. But histologically, you will just find chronic inflammation. That is non-specific. But one specific feature is increase in the number and the size of the glands. These glands, the mucosal glands, are hyperplastic and hypertrophic. There's mild increase in the chronic inflammatory cells. But one more important feature is squamous metaplasia. So normally the epithelium is pseudostratified ciliated columnar epithelium normally, but when there's chronic bronchitis due to smoking or any reason, because the chronic condition, the epithelium becomes squamous. To fight the irritation, to fight the chronic disease, it becomes squamous. Normally it is columnar. So this is also an important feature of chronic bronchitis. So number 1 feature is squamous metaplasia. Number 2, mild increase in the chronic inflammatory cells. Number 3, hyperplasia or hypertrophy of the mucosal glands, almost double the thickness of the normal. So all these glands are increased. In bronchial asthma, we know that it is a hypersensitivity or allergic condition, type 1 hypersensitivity, in which there is involvement of the eosinophils and IgE. This is the normal bronchus, and this is the asthmatic bronchus. You see the wall is thickened and the lumen is decreased. So these are the gross features. One can see the star. Gross features of asthma are thickened wall of the bronchus, narrow lumen, and you may see whitish mucus secretion. So this secretion is mucus, not the pus. So this is very important. In asthma, it is the mucus secretion because of the irritation and hypersensitivity. It's not because of the infection. When there's an infection by the bacteria, pyogenic bacteria, you get pus. So this is not an infection. It's only mucus, whitish mucus. So again, we have to see that before the microscopy of asthma, you see the normal thing again, same picture. At high power, you see this pseudostratified ciliated columnar epithelium, pseudostratified ciliated columnar epithelium, pseudostratified ciliated columnar epithelium. This is the one with some goblet cells in the middle, then mucous glands, and this is the cartilage. So these are the 4 important features of the normal bronchial wall. Again, when you look at the diagram, you understand easily. Before we go to the difficult thing of the real picture, let's have a look at the diagram. The normal airway has the epithelium. Epithelium is pseudostratified ciliated and some goblet cells. Goblet cells, they secrete mucus, which is very thin layer in a normal person. In the lamina propria, you see blood vessels and some occasional inflammatory cells. Then we have a smooth muscle layer, and in the submucosa, we see these glands, again few glands, and then cartilage. This is the normal bronchial wall. In asthma, you see thick layer of mucus. You see a lot of mucus is secreted by goblet cells. And in this mucus, you see eosinophils. Eosinophil is a characteristic cell of bronchial asthma because it's an allergic condition, because it is a hypersensitivity condition involving the IgE and eosinophils. So the basement membrane slightly increased in size, but the lamina propria is full of inflammatory cells. All type of inflammatory cells, macrophages, mast cells, eosinophils, lymphocytes, neutrophils, all cells are present, and these are the capillaries which are congested. All these 4 or 5 capillaries. The smooth muscle is also thickened because of the continuous effect of the allergic reaction, constriction of the lumen. The smooth muscle has to work hard, it becomes hypertrophied. And then the glands are also increased in size. You can see the increase in the size of the glands in the submucosa. This is the diagram. Now we see the actual microscopy. This is the picture from your textbook so that you don't see it in your file you received yesterday. So these, again, you see the mucosa is not so good, not preserved properly, but you can see these reddish things are the eosinophils. Eosinophils are the cells with granular red granules. So all these are the eosinophils, and you can see the hypertrophy of the smooth muscle. So these are the smooth muscles which are hypertrophied, which are thickened. These are the 2-3 important features you can see in the low power microscopic feature of bronchial mucosa in asthma. Again, a low power, but more detail. On the left side is the lumen. In the center of the submucosa. This is the mucosa, very thin mucosa, the epithelium. Then this is the submucosa, and this is the wall showing the cartilage on the right side. So in the lumen, you see a lot of mucus. Normally, you don't see this much mucus in the lumen, and some inflammatory cells, mainly eosinophils. At the low power, it's difficult to see. But here, you see congested blood vessels, dilated congested blood vessels, and between are the inflammatory cells, all type of inflammatory cells, including eosinophils and neutrophils and lymphocytes. And muscle is thickened. You see all these muscle fibers? These muscle fibers are thickened and hypertrophied. And then you have the cartilage on the right side. So you see the eosinophil count is increased in the blood also. Peripheral eosinophil count is increased. It is also, the eosinophils are also present in the sputum, which is expectorated out by the patient during the asthmatic attack. Again, at high power, now you can see a lot of them are eosinophils. All these are the cells which are having granules, and usually it has 2 poles, binucleated, that is bipolar nucleus. So this is a very important feature. I give an example that is like a person wearing on a beach with goggles, wearing goggles in the sunny day. So it is considered as a good cell or beautiful cell of in all the inflammatory cells. So this is a good question which we can ask. What is the important cell and what are the features of eosinophils? It has a bright red cytoplasmic granules. The next condition is bronchiectasis. This is also an obstructive lung disease. Sorry. So there's obstruction, or whenever there's obstruction and infection, there'll be inflammation. So there's a difference between infection and inflammation. You are in second year, but I'm sorry to say, in my third year, students also gave a wrong definition of inflammation and infection. So please make a difference. Inflammation is the response of the body. It's a defense system. Inflammation can occur because of hot tea on the tongue also, tea or coffee on the tongue, hot water, or allergies are also inflammation. They are not infections. Infection, when there is bacteria or viruses, they come. So please note a difference and don't say this when you come to the third year. So whenever there's obstruction or infection, there'll be inflammation. And when there'll be inflammation, there'll be destruction of the bronchi, and they get dilated permanently. When there's chronic inflammation, chronic infection, the bronchi will get permanently dilated. So the arrow is showing all these dilated bronchi in the mid portion, lower portion of the lung. The patient has recurrent. Now, what happens when they are dilated? They have secretions in them. There's inflammation, again more infection. So this is what we call vicious cycle. They continuously keep on increasing. The patient has recurrent infections because of the stasis. Stasis means now it's stopped. There's no flow of the airways. There's just stasis, and just like dirty water on the roadside, you'll see more dirty. When the water is flowing, it will be clean. Same is here. When there's no air passing through, this is called stasis, and more infection will occur. So that's recurrent infection. And finally, there's copious, purulent sputum production with cough. Copious means too much. A lot of it is copious. Purulent means full of pus, purulent or suppurative. Sputum is the secretion that comes out when cough out during the coughing. So this is the picture. You see these dilated spaces. Bronchiectasis. Ectasia means dilatation. You remember this is a common word, ectasia. You can see in other parts of the body also you will see this word. Bronchiectasis means dilatation of the bronchi. This is the picture I took yesterday from the Robbins. This was a patient suffering from cystic fibrosis. Anyone knows what is cystic fibrosis? Have you done this disease?
Yes.
Okay, mashallah. Okay, so this is a genetic disease in which there are some organs in the body develop cysts, small cavities like pancreas and lung. So when there are cyst spaces, they get fibrosed, they get infection. And in this case, the poor person has to go for lung transplantation. And when you see it is all full of bronchi, even close to the subpleural surface, everywhere full of pus. You see all this pussy material. So this was removed from this patient. Only this part is a bit normal. This is the normal lung, but otherwise all this is bronchiectasis, even going up to the pleural surface, subpleural region. This is the old picture you must be having in your file. You see all this area of dilated bronchi. We call it bronchiectasis, ectasia. It may be localized. Sometimes it involves the whole lung or whole lobe, but it may localize. You can be asked a question, what are the conditions in which there's localized bronchiectasis? There are two conditions. There are two conditions in which the bronchiectasis is localized. Number one, neoplasm. When there's tumor in a small part, of course, then only that part will have bronchiectasis. Second, when you get foreign body inside your lung, you aspirate foreign bodies, a liquid or any solid goes inside, then they will block the bronchi, and only that part will get localized bronchiectasis. So there are two causes of localized bronchiectasis. So this is one more question that has come into my mind. What are the causes of localized bronchiectasis? There are two. Number one, neoplasm. Number two, foreign bodies. This is another picture showing a lot of all these bronchi which are dilated. Some of them are also showing secretions. There you can see the pus secretion in the bronchi. Pus or purulent or suppurative, that same word, same thing with different meanings. Different words with the same meaning, sorry. So they are thick, purulent secretion, thick, suppurative or pus-like secretions. Now coming to the next disease, quickly we'll go through this diagram to understand. You must have seen better diagram by Dr. Ahmed in his lecture. I've seen there are more diagram, but just to simplify, your textbook has shown only two types of emphysema. This is a normal duct, this is normal acinal. In the beginning, there's respiratory bronchioles, alveolar ducts, and then alveoli. In the two main types of emphysema, there's dilatation of the proximal part. We call it centri acinar, in the more of the center, towards the center. Dilatation of the respiratory bronchioles. This is the centri acinar emphysema. The second type is pan-acinar emphysema, means it is more in the proximal and the distal type near the alveoli. That is the distal type. This is the central type. In this type, here they are normal in the, but in this alveoli and alveolar duct are dilated. These are the two types of emphysema. Okay, this is the gross picture of emphysema. You see there's destruction of lung parenchyma. You know, all these alveolar walls are destroyed. You see again spaces, all these spaces, but they are smaller spaces as compared to bronchiectasis. They are smaller spaces, and they are, here you can see they are larger, but overall, as compared to bronchiectasis, they are small. Here you may think they are also spaces, but this is the normal hilar region. These are the normal bronchi, the normal pulmonary vein, etc. So this is the normal area. This is not the dilated area. So, but these are the emphysema, the dilated alveolar spaces, and later on they may become blebs or bullies. I'll show you the blebs and bullies later in the next picture. This is the bulla. Bulla is singular and bully is plural. Bulla means one balloon-like space, bulla. So this is because there are many bullae, we also call it bullous emphysema. Lot of bulli or balloons on the surface. It's bullous emphysema. It can involve all the lobes of the lung, especially the base at the left. This is more common in the alpha-1 antitrypsin deficiency, which is the only one cause of panlobular emphysema. I hope you have been told about this enzyme deficiency, this genetic disorder, alpha-1 antitrypsin deficiency. You have been told? Yes? No? No one knows anything about alpha-1 antitrypsin deficiency?
We know it.
Okay, I'll just briefly tell you that this is a substance. It is an anti-enzyme. This is an anti-enzyme. It circulates in the blood, and it will block the enzymes, the proteases, like elastase is the important one here. It will block the activity of elastase. When this substance is deficient due to genetic disorder, then there's deficiency, then elastase becomes more active. And you know, the lung has a lot of elastic tissue. And because of that, it is producing its effect of respiration because of its elastic tissue. So when there's overactivity of elastase enzyme, then there's destruction of the wall of the alveoli and you develop emphysema. Emphysema is developed because there's deficiency of this substance, which will destroy or decrease the activity of elastase. And when elastase becomes active, it will destroy the alveolar wall. This is a postmortem case in which you see these ribs have been opened up. And as they opened, they found these emphysematous bullies, all these bullies in the lungs, both sides, the blackish one. This is an autopsy condition, autopsy picture, patient with emphysema. Anyone can tell what is this yellow structure? Yellow arrow pointing towards? Anyone? 1, 2, 3, all have gone. Anyone listening or not?
Yes, sir, listening, Doctor. Don't worry.
Mashallah. I don't know how many are listening because this is on the full screen. I wish I had knew how many are in the presence now?
Above
109.
More than 100?
Yes, it's 110.
Mashallah. But they just maybe connect and go away. No one is replying. Mashallah. What is this yellow pointer? Anyone? It is an autopsy specimen 2 lungs here, and what is here in the thorax? Simple question. It is the heart.
Trachea.
Sahi, heart. Okay.
I
So
can
there-
see a heart, Doctor. Is this
Yes,
heart?
that was a simple question asked. So what is this structure? This is the heart, and these are the 2 lungs. That was all I wanted to just change the mood of the people. Maybe some are sleeping. I was also sleepy after Fajr, but I said, okay, I'll give the lecture and then I'll sleep. Okay, so this is the bullous emphysema. Now we come to the microscopy. Before going to the microscopy of the emphysema, we look at the normal lung. So this is how the normal lung look like. Walls are just delicate fibroelastic tissue, which carries the blood capillaries. So this is the normal lung. And all the alveoli are full of air. So they are well aerated. But in emphysema, what happens? The walls are broken. There's loss of alveolar walls. So this is an important question, important slide. What happens? What are the microscopic features of emphysema? There's loss of alveolar walls. There's dilatation of the alveolar spaces. Normal spaces like this, small, but here's dilatation of the dilated alveolar spaces and destruction of the interalveolar septa. Sorry. So the alveolar walls are also very thin. You can see how thin they are because the elastin is being broken down. Elastase enzyme is breaking their elastic tissue. So they become very thin. This is the picture I yesterday took from the Robbins. There's marked enlargement of the alveolar spaces, destruction of the alveolar septa. They are broken down, but there's no fibrosis. This is the difference. We'll see which conditions have fibrosis. Those are the restrictive diseases. We'll come to that later on. All these up till now, after pneumonia, we are discussing the obstructive lung diseases. And this is one of the type of obstructive lung disease. There's no fibrosis, but you can see this black thing. This is the presence of black anthracotic pigment, carbon pigment, because we people living in the city may be having all these. The smokers will have this carbon, dark black pigment. We call it anthracosis. We'll do more about this in the second part of the lecture. So this is emphysema, when there's breaking down of the alveolar wall and alveolar spaces become very large. That was the end of the obstructive disease. Now we do the restrictive diseases or infiltrative diseases of the lungs. These are the diseases in which they are different diseases. We are not putting together. Only important thing is that there's fibrosis in them, little bit or more fibrosis that will cause restriction of the lung, because lung is an elastic tissue. It has a lot of elastic tissue. But if instead of elastic tissue, we have more fibrosis, it cannot allow the air to come inside. So there's a restriction. More, you must have been told, or I hope you understand the difference between the two conditions. So the more important is that now the lungs are not soft, they become stiff. They are stiff, so air cannot come in. It will not allow the air to come in because there's no space. They're stiff, they are hard now. And the patient has to breathe with difficulty. So when they breathe with difficulty, we call it dyspnea. This is an important table. I will not ask you all the details, but at least one should know that 4 types of restrictive lung disease, 4 types. I cannot remove that. I don't know whether you all can see that black bar at the top.
Yes. No, we don't see the bar. We
Oh,
can see
good.
clearly.
So,
Okay.
mashallah. So it is the 4 main types: the fibrosing type, granulomatous type, eosinophilic type, and smoking related types. These are the 4 types of restrictive lung diseases. Because of this, the lung becomes hard and it will not allow the air to come into the alveoli. And when there's fibrosis, when there's granuloma, like in sarcoidosis, when there's eosinophilic type, or these allergic type, and because of smoking, these things can occur. So we can ask you what are the 4 basic types of restrictive lung diseases. Although these are theory questions, but they can overlap. So this is the first type. What is written here? I cannot read it. Anyone read for me?
Interstitial pulmonary fibrosis.
Yeah, so interstitial pulmonary fibrosis means the fibrosis is between the interstitium, between the alveoli. And because of that fibrosis in the septa or in the interstitium, they are pulling on the, like, because of pulling effect, because fibrosis is like contraction thing. So they, because of pulling effect, they'll produce this cobblestone appearance on the surface. On the right side, this is the pleural surface. You can see there's cobblestone appearance. And when you cut the surface, you see the honeycomb appearance. So these are the two features of this interstitial fibrosis. There is pulling effect, and because of that, the pleura is also not smooth, and you see the stone-like appearance on the surface, and on the cut surface, it is like honeycomb appearance of the cut surface. This is the interstitial fibrosis. It can occur idiopathic or various other causes, but they have the same thing. They have cobblestone pleural surface, and cut surface is honeycomb. So how can we differentiate it from the emphysema? In emphysema, there's destruction of the walls, and there's no fibrosis. And in this condition, there's no destruction, but more fibrosis. That will make these big spaces because of the fibrosis. It will pull together and cause fibrosis. And in the emphysema, there's no fibrosis. So in this picture, this is one of the type of interstitial fibrosis. We call it usual pneumonia type of thing, interstitial pneumonia. It's all fibrosis. It's more near the pleura. There's more fibrosis in the subpleural region. You see all this fibrosis. But here, as you go inside, you see the normal alveoli. These alveoli are normal in the inside, but toward the surface, there's more fibrosis. So this is also a type of restrictive lung disease. This is the picture I took from the Robbins. Overall, another condition called pneumoconiosis. Pneumo means, anyone know what is pneumo? Pneumothorax, all these pneumonias. Yes, it is actually means air. It's not lung. So, mashallah. So this is pneumoconiosis is a condition related to occupation. So people, the poor people, they work in the coal mines where they get a lot of dust, carbon. They develop the coal workers pneumoconiosis, also called anthracosis. Some people working in the silica factories and building material, they develop the condition called silicosis. Asbestosis is now restricted. They are trying to ban this because of a lot of defect in it, because a lot of complications because of the asbestos. And the condition is called asbestosis. The disease is called asbestosis. We'll come to that more. Similarly, beryllium. And then because of the beryllium, one can get berylliosis. So this is a group of diseases because of the occupation. They develop fibrosis in the lung. There's diffuse lung reaction, diffuse lung fibrosis because of the inhalation of these particles during their work, during their occupation. But we people living in the cities can also get these anthracosis very commonly. The smokers can get anthracosis because of the smoking. But overall, mainly they are because of the occupation. The whole group is called pneumoconiosis. So this is the pneumoconiosis because of silicosis. This is the subtype is silicosis. You see the pleural surface is on the left side. And on the right side, we have the hilum. These are the bronchi and the pulmonary artery, pulmonary veins. This is the hilum, has been cut. And you see this dark area. This is fibrotic and it's tightened and dark in color because of the presence of silica particles. This is scarring or fibrosis is in the upper lobe, and it has made it a dark, small dark areas. The lobe has shrunken, it has become small because of the silicosis. And this is a microscopy of the silicosis. There's fibrosis, this is hyalinized fibrosis and some chronic inflammatory cells, but you can still see some normal alveoli at the periphery, some dilatation, but because main thing is the fibrosis because of the silica. Coal workers, when they work in the mines of the coals, they get the condition called coal workers pneumoconiosis. It is also called anthracosis. You see a lot of dark black pigment, the carbon, all this is all carbon. And because of the carbon, there's a lot of fibrosis, all this solid area. Normally it should be, lung should be like this, with full of air. But this area has become fibrosed and leading to all the problems of restrictive lung disease. So this is the example of coal workers pneumoconiosis, also called anthracosis. Then this is the most important condition, asbestosis. Because of the presence of asbestos, this is a substance which is also used in the building factories. They're on the roof material, which is now it has been banned in the Western countries at least, but still one can see in the poor countries, asbestos is a very dangerous substance. When it goes inside the lung, when person breathes in, then develops the condition of pneumoconiosis, asbestosis. There's a lot of fibrosis, especially the pleura. See, this is the pleura inferior surface and the lateral surface, they get fibrosis, fibrous plaques and fibrous nodules on the diaphragmatic surface of the lung and the visceral surface of the pleura. Everywhere you can get this fibrosis in the beginning. Sometimes also when it is serious, the fibrosis goes inside the lung also. But usually it is on the pleura most of the time. But this condition is in the beginning, you get only pleural fibrosis, but later on it can become malignant. Before that, we go to the microscopy. You see, this was the picture I taken from Dr. Aladdin's lecture. It's also present on the internet, that these are the elongated asbestos bodies. They cannot be digested, they remain, they become chronic, but they can get iron around it. They get rusted, so that is why they are called ferruginous bodies. They are brown in color and they will cause all irritation. This is carbon, this is different. See, this is different, carbon, granular, but these needles, this needle here also, are the asbestos bodies. When we do the postmortem, we are asked to do, because when a worker working in the building factory develops a disease of malignancy called mesothelioma, they sue. They go to the court and say that this building company has made me get this cancer because he made me work in the asbestos. So when they die, maybe after 30 years or 20 years, then we have to do the autopsy and we have to confirm under the microscope that they have these bodies. Only then they will get the money from the company, the building company. They will give. This is very common in the West. In the UK, we regularly used to get 2 or 3 cases in a month. We have to do hundreds of sections to see these asbestos bodies. So the most important problem with asbestos is that person can get a malignant tumor of the pleura called mesothelioma. See, all this is a mesothelioma tumor. Mesothelioma means tumor from the mesothelium. Mesothelium is present in the peritoneum also. In the pericardium is also mesothelium. All these are the mesothelium. So any tumor, the malignant tumor arising from the mesothelium is called mesothelioma, but is more common in the lung because it is inhalated. The asbestos bodies are inhalated, but they can also go into the GIT and cause the mesothelioma of the peritoneum. But more commonly, it's the mesothelium of the pleural cavity. All this, the malignant tumor, is a dense white circling tumor mass arising from the pleura, and they may appear as nodules and plaques. It's a very bulky tumor. Person usually dies. The same asbestos can also cause bronchogenic carcinoma, the carcinoma of the bronchi, the squamous cell carcinoma. So it is also a dangerous substance which can cause mainly mesothelioma, but can also cause bronchogenic carcinoma. This is the picture which is not present in your e-plate form file. This is the fresh picture. It's all mesothelioma, gray-white tumor. And the lung has become very small. This is the only little bit of slung here. So it has engulfed and eaten up the lung, compressed the lung, and all this is the tumor. These are all these autopsy pictures. We take sections from here, take just small sections to confirm whether there are asbestos bodies or not. And finally, empyema. Mesothelioma was a disease of pleural cavity. So this empyema is also a disease of pleural cavity. Anyone knows what is empyema? It is written there, pus in the pleural cavity. But I also found out that empyema can also occur in other parts of the body. Empyema means pus in the cavity, actually, but it's most common in the pleural cavity. That is why more commonly when we say empyema, it means pus in the pleural cavity. You can see this pus and membranous thick structures on the surface of the pleura is the empyema, when the pleural cavity is full of pus and it can attach to the pleural surface. So this is how it looks like on the gross specimen. The other two organs which I found can also be called empyema. One is the gallbladder. You will hear that gallbladder, when it's full of pus, we call it empyema gallbladder. And also in the brain, in the subdural space, you get in the cranial cavity, if the pus in the subdural space, we call it empyema of the subdura. So these are two other places where this word is used, but more commonly it is used in the pleura. I think this was the last slide. Thank you very much. Any questions you can ask now or you can ask later on. Okay?
Doctor,
Yes.
can you say in this slide for us?
Yes, I will send it to Muhammad just now. This
Okay.
because I added these yesterday night when I was revising. I saw there are good pictures in the Robins, so I added them now. I'll send it inshallah just now. Okay, ma salama.
Thank you, Doctor. See you later.
Thank you. Ma salama.